Hello, everybody. Welcome to the next episode of Digi4Care. After the introduction to the health project, now it is my pleasure to host three guests, and we will be speaking about financing and health policies of this project. So on my left side is Kristina Davidovic. Kristina, welcome.
Thank you for having me.
And on my right side is Johannes Weiss.
It's a pleasure.
Thank you. And Laszlo Lorenzovic.
Thank you.
Pleasure to meet you. Let's start with the introduction because not all our listeners and viewers are aware of you and your background. So, Kristina, let's start with you.
Okay, I'm a legal and health policy expert at Semmelweis University in Budapest, and my main research areas are health policy and system-related questions, especially regarding legal and regulatory issues. And on the other hand, data-driven and especially AI-based tools related legal and ethical issue in terms of implementation in healthcare system. So it's a mouthful, but...
Thank you so much. Johannes, what about you?
I'm from the Austrian National Public Health Institute, where I'm, let's say, since 5 years in the international department, focusing on health policy there.
Thank you so much. Laszlo?
I'm Laszlo Lorenzovic from Romania, from Hospital Consulting, and I'm a medical doctor and economist, health economist, and in this project we are offering support in financing and costing and cost efficiency analyzing.
Thank you so much. The common question for all of you, how did you find out about this project and what made you pursue it that you want to take part in it? Kristina.
It's a kind of hard question because the whole project covers many things around digital tools and of its implementation of those. But from my perspective, the most important thing is how to thinking about these pilots and endeavors in terms of more broad perspective, even if all the measures and all the activities are very institutional level, and thinking about how can those results of scaling for a higher activities and how can those used by each countries or even regions.
Thank you so much, Johannes.
That's perhaps a funny thing because we were invited to enter the consortium at a very late stage because piloting digital solutions, it is nothing that our institute is performing usually, but Digi4Care tries to put it on a second level, on the next layer, on the policy level. And so, in fact, the other Austrian partner, the LBE, invited us to join the consortium to take over this part for this policy level part.
Thank you so much. Laszlo?
We were collaborating with Semmelweis University already on academic and research level, and we were invited based on our expertise in healthcare financing and cost measuring in healthcare.
So, Laszlo, let's stick with you. From your perspective, why are the financing models crucial for digital healthcare adoption in a broader sense? Because in this project we have various pilots, and those pilots has to be financed somehow, also from the sustainability point of view.
If we are discussing about a new medical service or new medical technology which is not financed at the moment in any country, the question is always we replace an existing service with another one, or this is a completely new service. If it's a completely new service, from the health policy and decision maker perspective, there are two options. or they invest more money in healthcare, or they will rethink the financed service package and renouncing some existing one and putting something new one. If we have the first option that we're replacing an existing service with a more efficient or a cheaper option, the decision is more easy because we don't need to bring new money in the healthcare, or we don't have to renounce to an existing service and cause some problems with another patient groups.
You are comparing the healthcare system because you're the member that is also focusing on financing, and all of the countries that are participating in this project, their model of the financing of the healthcare is a little bit different. Some have many insurance companies, some have just a few insurance companies with the possibility of having additional insurance, etc., etc. You would have to describe the main differences or the most important differences regarding the financing in various countries. What would be the answer?
Of course, 7 countries are involved in this project, and in these countries, the healthcare financing is quite different. In some countries, like in Slovakia, the private financing, private insurance is more represented compared to other countries, like Hungary or Romania, where we have public mandatory insurance system.
The same in Slovakia. There's a public mandatory insurance system in Slovakia as well.
With more focus on more share of private providers in Slovakia. What could be different? The motivation of a private provider, it's higher if is a huge financing incentive to do a service or not, or to extend the service or not. If we have a public provider, this type of incentive could be a little bit different, because they can make cross-subvention between different services. And from this point of view, it is important that the financial motivation is there or not.
Thank you so much. Christina, we would have to explain how are the countries adopting towards new trends, new technologies, also from the AI, but from the legal perspective. Are the system in the various countries, in those 7 countries that are participating, flexible enough, or they are more rigid?
This can be a common feature that, so in terms of regulatory frameworks, all countries are very rigid. I mean, traditionally, because technology is, I used to say that it is an international thing, so a global thing. Meanwhile, the regulatory part is always very local. Feature saying so, and there can be also differences between region in the same country. For example, in Austria, so I think it's so fragmentation is a systematic inherent kind of part of this whole thing that we can we have to face in an implementation of new technology.
Thanks so much, Johannes. If we take a look on the whole Danube region, all of those countries face major differences in digital maturity and health system structures. Peter Pajitny in the previous podcast has mentioned that the countries who are probably the most advanced in implementation of digital solutions and of the whole digitalization of the healthcare is Austria and Czech Republic. How is the digitalization of the healthcare influencing the implementation of the finances and healthcare policies?
I'm not pretty sure if we have most experienced in this section, but of course I think we have in a very early stage experienced with what we have also in the beginning of the project, have also experienced this the private-public partnerships. That's a combination for startups, let's say, in combination with public bodies, and to come together and invent some gadgets, some new technology. I mean, these public-private partnerships are not every time easy, because the public part is often understood as a collaborator just. But these partnerships is very has had great advantage for startups, because they bring up sustainability, financing sustainability, and of the technology. Because what's the problem when a startup it got bankruptcy? What's done? Then perhaps the maintenance of the digital solution ends. What's then? Then you have bought a gadget, hospital bought a gadget, it invented it in its processes, and company cannot maintain it anymore because it doesn't exist. So this public part brings in this sustainability for both sides, for startups, but also for the patient, who can trust in this technology. And that's a point. We are often talking about barriers, ethical barriers, and these things. But I don't think that these barriers, that's the right word often, because barriers are also a good thing. They ensure trust for the patient. So I think they should not be an extra burden, you see, a hill to climb. But if they are implemented in the process to make the framework in which this pilot or project can develop, that's a very positive thing, I think.
Thank you so much. In general, you can react whenever you want, but let's move on. What are the biggest financial barriers for scaling digital solutions in the Danube regions? You can make maybe a comparison also between the countries.
In my opinion, the financial barrier appearing when the existing providers have not interest, or they have opposite interest to be adopted a new technology on the market. Maybe they already use, for example, if we're discussing about ophthalmology screening, the ophthalmologists, they think that they will lose their patients, their income, and their lobby will make an opposition to a new technology.
It's a little bit funny because sometimes, the specialists say that we have too many work to do, take some work from us, and then when somebody wants to sort of help them and move the competency, for example, toward general practitioners, then they are protesting.
Yes, we have the same problem with the diabetology, for example. And also in this project included this area. And of course, it's not easy for the payer, for the health policymaker to maintain an equilibrium between these forces. Usually not the money problem is that, because these new services should be included in an existing pattern, and usually these services should be approved some professional bodies. For example, in Romania, there is a commission of diabetologists, commission of ophthalmologists, different commissions. And of course, the personal resistance to these changes and to broaden the profession for other providers is not easy for them. And there is a natural resistance for this type of changes. And this, of course, this is an obstacle to change the financing rules. So,
I believe that it's financing rule. That's basically also the question for all three of you. That sometimes or a lot we hear that none of the healthcare system is in Europe are financially sustainable from the long perspective, because the new technologies are coming. We can cure the diseases that it was sci-fi to be cured just a few years ago, and there will be a huge financial pressure towards all of the systems. So the common question for you: how are the various countries dealing with this fact, and are they even able or capable of admitting that probably without additional finance, not necessarily from the state or from the government, we won't be able to finance the healthcare?
Generally, this announcement it's true, but if we take a specific technology, which, for example, bring more efficiency and maybe less unit cost.
Yeah, then it's easy to pursue.
Could be easy, but the existing mechanism and decision bodies and decision makers and decision behaviors actually build an obstacle on the front of these new technologies also. And for example, of course, who will pay the note for all these? The patient and the taxpayer.
It's always taxpayer.
Yes.
And so to come back, what you said about the practitioners. So to say in Austria, it's the case that even we have good solutions, it's often a lack of support for practitioners, not only financial support, but also technical advice, so that the solution can be perfect, okay? But to implement it, that's the problem then.
Yeah, but let me share a concept about this, because at the early level of theory, it's a very well-known issue. I mean, there is a dilemma, the so-called Collingridge dilemma, that we usually referred in the field of the legal field, which is about information and power imbalance in this era. When new technology is emerging and there is a hype around it and everyone wants to use it, there is a huge problem. I mean, twofold. We do not know how it works, yet. And another thing is that we also do not know what kind of implementation it will have on the society, or even at personal level. And when over time, of course, by using it and having more experiences about all these things, we would obtain more information that would be needed to better regulation or better technical guidelines. But by then, we will have so many actors at the market, in the market, which have all
various actors and various interests.
Yeah, that was I about to say. So in very many interests that we are be very competitive, and because of that, it will be more and more difficult to find good rules and frameworks that can be used for patient safety and financing logic, or anything that would be important for a system. Because at that time the system will be a bit more, so we have less power to do that.
Mm-hmm. Yeah,
and let's connect your.
Yeah. Just to illustrate, I think what you said, because an example from my daily life, when I'm going to the doctor with my children, and he's got some new technique solution, and he tells me it's nonsense, it won't work. then I have to trust him because he's the doctor. And when he says it won't work, it's nonsense, don't use it. So I'm the patient and I must trust him.
And that's why such a project like this one is so important, because we can gain some experiences that is from right from the patients and from the practitioners, and maybe we can stepwise closer to some facts that can be used also at the system level approach.
Last one. You want to react?
If you're discussing about, of course, from patient perspective, taxpayer perspective, they would they expect more value for their money, okay, and not more money for the value. And it's very important that the value can qualitative component and quantitative component. For example, if we use digital technology which can be used cheaper than an existing one, we can offer more services, more quantity for more people, which at the moment haven't got access to that technology. For example, some examination on diabetic retinopathy or cardiac device or diabetic screening or otherwise, if other type of technologies. And still in this part of Europe we have problems with access, so with the quantity.
With the access of the new technologies?
In general, access to
drugs, etc.
In general, to access to services, because the health insurance or a public payer, called public payer, haven't got enough resources to buy for everybody, or haven't got human resources to offer service for everybody, because this is also a problem. And for example, these technologies can bring two important things: could reach more people technically, physically, without more trained healthcare personnel, which is not enough, at least on countryside or less developed part of different countries. Or with the same money you can provide more services. And from this point of view, we have to discuss about quantity of services provided and physically access to the services, because general barriers in healthcare system to the services.
One of the barriers in the healthcare sector is also basically the cross-border cooperation, and we have already discussed that all of the healthcare systems in those seven countries are a little bit different. So, Christina, how does policy fragmentation affect the cross-border cooperation?
I think very much. So, as far as I know, for example, in this project, if I'm not mistaken, in pilot 4, there was we want to deploy the same tool in 3 countries. But for example, in Australia, it was said that it doesn't comply with ethical requirements, and because of that, we cannot do the same thing there, which we can do in the Czech Republic. So this can be very decisive, and it was very important to us to see those things, because we can learn from that, and we can those learnings implicate further projects and further endeavors in this realm.
So, Johannes, basically, Christians also have mentioned that the fragmented systems are inconsistent with the national policies.
Yeah, sorry to come back, just one more example. I think it was pilot 2004 in Bosnia-Herzegovina, where it was really a problem to bring the gadget into the country.
Literally to bring it.
Yeah, to bring it. So the idea was during the last peer review visit that the Austrian partners, it was really there, they can bring it in the car with them. But it was no solution because it was far too risky to import it.
But it was like sort of illegal to bring it to the country? Or?
Yes, it was sort of illegal because I don't know exactly why, but there were some requirements not fulfilled or something like this at the border. I don't know exactly why. But it was a really problem to start this pilot, not because the gadget was not ready, not because the clinics and the patients wanted to participate. It was
because of the law.
Because of the law, in the end fact. Yeah.
So let's hope that Bosnia will join the EU soon. It will make things much more easier.
But perhaps it's a good example for.
It could be also the good marketing for the EU. Come to EU, you will have an easier life when bringing the gadgets for the healthcare.
The pilot is still is now going on. So
and the problem was sorted out, and now colleagues in Bosnia are able to use those gadgets, right?
Yeah, of course.
Okay, but this is also the problem of the fragmented system and inconsistent national policies. So to your comments towards that, we have already mentioned some of the example from Bosnia, and also from the Christina has mentioned some of the disparities with the Austria from the ethical point of view.
Yeah, I cannot say about the ethical point of view. That's new to me.
I read in a midterm review.
Okay.
So I would say that in details we cannot tell anything about the project because the final results are not ready or at hand yet for us. But there are overall reviews about the processes. So that's why we can mention some examples, but not in more details. We will examine those details, and based on those we can put evaluation and strategic documents develop, but so these will be the tasks of the months ahead us.
The general question anybody can answer: how does the project support the policy harmonization in all of those 7 countries that are participating? Who's the quacky one?
I would not say that we can harmonize the policy. That's too broad.
It's not a systematic goal of this project. It's more about learning from each other and apply pilots' experiences and how to collaborate with so many different backgrounds. So people with different backgrounds. So I think it's more about that.
Yeah, but of course, and that's a great advantage of this project. I think we have at the end of the project we have this big repository, this knowledge base.
Which platform?
And network as well.
And network.
Along with a toolbox that any country basically can use wherever.
Yeah, dashboard integrated in the knowledge platform. I'm not entirely sure about the wording, sorry. But that's something we at the end would like to support the policy and decision makers with every information they need. They want to know out of this project. And this, of course, can help to scale up these pilots in all countries or some country.
Can we already say that which pilots we have 4 pilots together highlighted the need for the policy reforms in various countries?
Yeah, it's a hard question. That's why we are just thinking about it. Because, as I said, it was conducted as a very institutional level effort. So I think this last part will be about the thought process, how we can upscale this, how we can build up action plans as an institutional level that can bring a further change and changing in that or this or that system. It's not the first.
Will be settled maybe later.
Yeah, and not.
Last one. What?
You wanted to say something.
I would be proud at the end when Digi4Care would be a best practice how to set up pilots, because I think the great thing is that's not it's not piloted just in one setting, in one national setting, but the same pilot is implemented in different settings. Over the
different setting, different conditions, probably different financing,
different backgrounds from the patients and everything. And if this could be a best practice for the future, this would be great. So this would make me really proud to be part of the project.
Thank you. Laszlo, what financing models or mechanism does Digi4Care explore in general, also related to the projects, to pilots?
When we're discussing to introduce in the existing financing system a new technology, usually it's easier to find a way to introduce to the existing mechanisms. But time to time it's needed to implement new things. I can give you an example. For example, in Romania, we don't have yet any payment mechanism, for example, to cover a digital cost. For example, to have a subscription to a software platform and to pay an amount. Of course, these not necessarily need a new mechanism. It can be put on the row as another option on the table, for example. Usually the financing rules contains a lot of tables with services, but needs a totally different approach and mentality change. Because, for example, in Romania, the mentality on the decision maker is that the doctor should be there. Doesn't matter where is the patient and how they work.
Despite the fact that probably Romania is also facing the problem of not sufficient amount of doctors, right?
Actually, we have a paradoxon here, because we have too many doctors in some specialties in some places and not enough doctors in other specialties and other places. We're discussing about relative lack of doctors, not an absolute lack of number of doctors. But this situation is caused partially because this mentality that the doctor should work in other places through digital tools, for example, in imagistic services or laboratory services or many other services, because if you have digital tool, and this is important from this point of view, the mentality changes maybe is more important.
The mentality of the changes of the mentality of the doctors or of the patients, or both?
Decision makers is the most important. I think, at least in our countries, the biggest problem is the mentality change of decision makers, because the patient already use different devices. They have smartwatches and other things. Not all, but most of them, a lot of them. The doctors discussing with other doctors from other countries, because they meet each other in different conferences and other professionals, so they know what is the situation in different countries. Of course, there is a resistance from the doctors at an age group. It is general technology capacity to use different technology, smartphones or other two smart cars or any two smart kitchen devices or anything. It's difficult for an age group, and we can see also in our countries this age split. And of course, from the patient point of view, it's not easy after an age for a patient to use and to manage the complex technology.
Do you think that maybe we are underestimating the elders?
Of course, if we are discussing about how
because
many...
old Ronald Reagan joke was that don't explain computers to me. I'm from the generation that created them.
How many elderly people has smartphone and Facebook on
I would say quite a lot of them.
A lot of
Sometimes
them,
they even have more Facebook profiles.
Of course, things are changing, and these changes can be accelerated by the relatives, by the kids, by the grandchildren who can help the elderly people to adopt a new technology. We can observe this in our family also. So the intergeneration cooperation is important. From also in healthcare technology usage, and maybe should invest the system manager in education and training also from the medical doctors.
So the implementation of the new professions in the healthcare in general.
Because things are changing, and for example, in Romania there is a point system in continuous education, but who gives these points? The Romanian Chamber of Physicians, but gives the same incentive for new technology trainings or participation on different projects or not. This is mentality change also in different organizations, and the incentive is important. Could be different financial incentive or professional incentive or any type of incentive in every level.
So also basically you are telling that maybe we don't need that much of the finances reform than of the mindset reform?
In case of Romania, surely it's true. I don't know what is the situation in other countries, but...
We are going to ask. What about Hungary?
Yeah, I think it's also important, and I was thinking about that. That can be also one reason why our project can be important, because this was focused mainly on the acceptance of patients and healthcare professional side. So we wanted to know whether they, or what are their perceptions about these new tools, and that can be a first step to this mind-changing process in various terms. So identifying the barriers and facilitators at that level can be of huge help for decision makers, whether this or that direction can be helpful or not. So I think, mindset is very important, and it can be turned to other policy changes, financial changes, everything in the system at the higher level. If we find good measures and we can evaluate the results in a helpful way.
Johannes, what about Austria?
It's a very important point for Austria, because with the population, with a very old population at average, there's a big topic, because there are also no patients who could use the devices, but who use the appointment by the doctor to go out at least once a week, to have the opportunity, to have the chance to go out. So this mindset is very important to change. Because on the one hand, we have the digitalized oldies, of course, but also in the generation of my parents, the same patients who refuse to use smartphones or gadgets because they want to see the doctor, to look into his face. and not to send the data
but
to...
it's more about their habits, right? And about the need for socialization to meet somebody alive.
But I agree with Shimon that there are many elderly who use very intensively these tools and social media and everything. So I think it's not just a thing for young people. It's just another. So we do need a different approach to different parts of the population.
And on the other hand, the patients has to be motivated to do that, because if they still have an opportunity to see a doctor alive, and basically they go to see him because they can, or maybe because it is free of charge, then there is no motivation to use the new technologies, isn't it?
I don't think you won't reach the population which is still refusing it. So I think it's a time gap. So taken 10 years, 20 years, it will be totally different to nowadays, I think. But
it will be out of necessity. That we
but
won't have any other options.
It works. So if you do not have access to healthcare professionals, then it will be a trigger to use any kind of tools that will give you answer to your questions.
Actually, if one part of the population will adopt earlier these technologies, the medical doctors will have more time to invest in other part of the population who are not so quick in adopting the new technologies. So both categories will have a benefit. And of course, there is the changes we have a transition time and the penetration speed, if we can see that. And on this process, actually, the whole patient group will have benefits because the time of the doctor will be used more
efficiently.
Exactly. Of course, there is a part of the population who need the personal contact, because there are some people who are the only people who listening them. The doctor, the family doctor, for example, and this is a social part, not actually a medical part or healthcare system part, and we should be able to manage this. Of course, in this part is important social assistance too, because not necessarily the doctor should be this person. The question is how developed is the social assistance in that area.
Thank you so much, Kristina Davidovic.
Thank you.
Thank you, Johannes Weiss, and thank you, Laszlo Lorenzovic.
You're welcome.
And thank you for watching us.